Hello, everyone. Welcome to the Day 2 plenary session. Thanks for being with us. I'm Laurie Watanabe. I'm the editor of Mobility Management Magazine, and it's my honor to be here with today's panel of global experts and American experts as well, sitting over here to my right. I'm going to introduce them in alphabetical order, even though they are not seated in alphabetical order, and I'm also going to ask each of them to kind of raise their hand and give a little wave so that you know who's who. So I'm starting with Matt Berwick, MA, is the Program Manager, Disability Accommodations and Clinical Services for UPMC and teaches at the University of Pittsburgh. Matt is also president of United Spinal Pittsburgh. Helen Cochrane is an assistant professor and program director for the University of Pittsburgh Master of Science in Prosthetics and Orthotics. Helen is the chair of the International Society for Prosthetics and Orthotics Education Committee that accredits prosthetic orthotic programs around the world and has worked in Southeast Asia establishing prosthetic orthotic education programs and clinical services. Simon Hall is the manager of assistive technology and specialized seating department at Central Remedial Clinic in Dublin, Ireland, and Simon is the founder and director of the European Seating Symposium. Alex Kamadu is a South African-trained occupational therapist and executive director of the International Society of Wheelchair Professionals. In the United Kingdom, Alex worked as an OT, seating therapist, and wheelchair service manager and held strategic roles in the Department of Health and NHS England. Kyle Walker is the RVP North for Reliable Medical, a multi-state post-acute DME respiratory and complex rehabilitation technology provider. Kyle volunteers his time with RESNA on 2 boards, the Development Board and Professional Standards Board as the vice chair. Kyle regularly reviews scientific papers in assistive technology and is an advisory board member for the University of Pittsburgh Master of Rehabilitation Technology program. And Deb Wilson is the training lead at Seating to Go, New Zealand, and the New Zealand chair of the Oceania Seating Symposium. Deb was a member of the project team that developed the 2010 New Zealand Ministry of Health Wheeled Mobility and Postural Management Credential for occupational therapists and physiotherapists. Seating to Go facilitates the credentialing workshops that form part of the competency pathway. So that's everybody. Thanks for being here, our panelists. And as background today, let me just kind of introduce the topic. I'm going to give you a little bit of history about education requirements and credentialing for disciplines that are closely related to seating and wheeled mobility, to see what kind of example we have that we could possibly follow. So in the United States, certification for occupational therapy and physical therapy was first required in the 1920s. By the 1940s, the OT field required a bachelor's degree, with licensure coming in the 1970s. Licensure for PTs began in the 1950s, with the PT field first requiring a bachelor's degree in the 1960s. By the 1990s, the educational requirements for both OTs and PTs was a master's degree. And currently, a doctorate degree is required for PTs, with a doctorate degree required of new OTs starting later this decade. So let's compare that to what's required, for instance, in orthotics and prosthetics. Certification for that field in the United States began in the 1950s, with O&P requiring a bachelor degree in the 1980s. Licensure for O&P came in the 1990s, and in the 2010s, the O&P profession began requiring a master's degree. So in these fields, what we've seen is that becoming more professionalized started with certification, then expanded to licensure, as well as increasing educational requirements, starting with bachelor's degrees and going up to graduate degrees. So where are wheelchair professionals by comparison? If we use the progressions in occupational and physical therapy and orthotics prosthetics as a sort of yardstick for us, then assistive technology professional certification, that's the ATP certification, is the first step in our process. The ATP credential recently turned 25 years old, and the Seating and Mobility Specialist, the SMS, is well into its teens. In 2022, NART's The National Registry for Rehabilitation Technology Suppliers turned 30, and the World Health Organization, WHO, just published the Wheelchair Service Provider Curriculum. So today our panel is here to discuss the current and possibly the future state of credentialing in complex rehab technology. And we'll hear about credentialing models outside the United States, as well as a successful credentialing model from another industry that complex rehab could possibly use as an example in its own credentialing journey. So we're going to start right there. We're going to start with what credentialing potentially means to everybody, and I'll start with a question, sort of throwing it out to the whole group. What does credentialing mean to you? What should a credential establish? Just as importantly, what does a credential not necessarily establish at all? And I'm going to start with, should pick. Does anybody want to start first, or else I'll just start picking?
I'll get it over and done with.
Thank you.
Kia ora koutou. In New Zealand, we have 3 official languages. One is New Zealand Māori, so kia ora koutou means welcome everyone, hello, and then English and the New Zealand Sign Language. So credentialing to me is a process of verifying and demonstrating any prerequisite qualifications and any required knowledge and skill required for a particular role, and in this case we're talking about wheelchair and seating professionals. It follows a structured and transparent process or pathway of learning and development, and it results in the awarding of a credential if you meet those requirements. I think the advantage of credentialing is it provides credibility and confidence both for the service users but also for the clinicians. And it's a potential pathway for future career progression into a specialist area of practice.
Alex?
I'm happy to go next, Deb, because we've got actually 11 official languages in South Africa, so I think we top you. Let's hear them. Simon says you don't have time. So just to add to that, I think credentialing is about validating and a comprehensive process to evaluate one's credentials or qualifications. But it can also be done by evaluators, employers, regulatory agencies, special interest groups. And I think just to add to that, I think that credentialing should not be about necessarily self-interest, but about improving patient care. And one of the things that I just want to highlight is that it can be a very costly and time-consuming exercise for individuals, particularly in low-resource countries. So it should not become a barrier to individuals giving the best possible patient care. So I think that if governments and regulatory agencies can make it more accessible for individuals to be able to achieve credentials, they should do just that. Thanks.
Thanks.
Laura, I may add to what Deb and Alex said, and in the United States, the payer landscape, I believe that it should help to reduce that administrative burden for that prior authorization, the funding, to secure funding, and I think we're making progress, but we're not there, and I think we'll continue the discussion today a little bit, and when you look at, Alex, you mentioned quality care or those patient outcomes, that is something I think we need to continue to examine as an industry with all stakeholders of what is this credentialing driving.
In Ireland, we have 2 languages, and I speak both of them fluently. Not really, but Céad Míle Fáilte, credentialing. I think it's very important. In Ireland, we all start off with your bachelor's degree, your master's, etc., etc. That's fine. This area is complex rehab, and the only way you can learn it is on the ground. You can't do it from a textbook. You can do it, you can get the fundamentals, but unless you get your hands on a client, you'll never get to the other stage. So we have a system where we have clinical specialists. So we take the OT profession. So how much time would you spend in seating during your training? Probably very little. Same thing with physiotherapy. So when I see people coming in to the area, it's a very, very complex and specialist area. It's very important that you can actually measure the outcomes. And the only outcomes you can measure is really clients. And if there's a problem, then you need to be able to hone in on that problem. So when I listen to all the different credentials you have here, it's excellent, because you end up in a situation that you've got so many people that make it. It's a multidisciplinary team. There's not one profession can see a client and say, this is the answer. If that's what you're doing, well, good luck. I don't believe in that. I mean, I see we have OTs, engineers, PTs, we've got speech and language therapists, but even down to our admin staff, and I don't mean down to our admin staff in any derogatory term, they know when there's a situation that needs to be dealt with straight away. So I think that when you're on the ground, it's a totally different situation, because you can never pick up your textbook and say, this is going to solve this problem. It's down to knowing who can solve the problem and knowing when to refer on. However, you do have to have that baseline. And I think weeks like this are fundamental to actually keeping you in touch with what's going on in every area of the world. And particularly at the European Seating Symposium, it's fantastic. I love ISS, but I love ESS more. And with that, I'm going to stop talking.
Yeah, so as an end user with a background in education, one of the things that I always think about with credentialing is, and I think we can all recognize this as we've all been in school, is those folks that have credentialing as teachers, it gives you a level of confidence and a level of trust. And as an end user, as a wheelchair user, I think that's one thing that we have to think about in this field is credentialing gives a level of trust, and it gives a level of confidence that the person that is prescribing and working with me to make sure that my seating is the best that it can be, it provides that level of trust and a level of confidence in the provider.
Thanks, Matt.
I guess I'll take in the last few comments for this topic, but I think a lot of really good areas have been covered, and one of the areas that I wanted to kind of highlight is for people that we all had real sweaty eyebrows when we went to do our exams and our tests, because that credential is so important to us, right? Knowing that this is something that is going to demonstrate the trustworthiness of our discipline, the depth of our knowledge and our understanding. One of the things that we should also remember is that credentialing is the minimum entry to practice, so that it is not a barrier to moving forward. So if you're struggling with the credentialing, it means you need more work. It also means that as leaders in these industries, the people that are in these rooms looking at the science, really trying to build those relationships or work through those networks, there's other steps beyond that that become necessary in order to be those leaders, right? That we don't want to just aim for the lowest bar in the room that says we are safe, we are appropriate. These are really complex situations, and investing in your personal and professional development protects you, and it protects your patient, and it protects the industry as a whole by ensuring that there isn't somebody 3D printing a wheelchair and selling it, right? Or doing some of those other activities that we have to really worry about when there is no oversight. So we have lots of legislative things that are required in higher resourced and well-resourced countries, in low and middle income countries, or in less resource settings. So there's countries and places in this world that have a lot of money and absolutely no industry, no professional qualifications or protections for people. And those are some of the places where some of the biggest risks happen. And if we want to ensure that the whole world moves forward with the best quality of care and service, we have to remember that credentialing it's always challenging when you're entering, because it takes so much and so long to get there, but also that it sets a clear bar, and that we should be encouraging as many people to meet that minimum standard as we can, so that we can start to develop our leaders as well.
Sure, Kyle.
I got actually a question, and Matt, this is actually for you, Matt, from a consumer. You mentioned that trust and level of education that comes with the credential, but from you as a consumer, is there an expectation from you that comes with someone that has a credential, and what does that look like for you?
Yeah, I think that's definitely a good point, that I expect that the people that are working with me to prescribe my chair have a level of understanding, have a level of knowledge. And I think you can only do that with credentialing that proves that they have that level of understanding and that level of knowledge. But it's not just that basic level, but it's also that continuing education, so that new things are coming out on the market. When I get my chair, I want to make sure that it's the best that I have. And if somebody hasn't had continuing ed on the new things that are coming out, I'm stuck in that chair for 5 years, that it's not going to be the best that it can be for those 5 years. So
Sure.
continuing ed is definitely part of that whole credentialing process.
Fantastic start. Thanks, everybody. Alex, I'm going to turn to you now. You're the Executive Director of the International Society of Wheelchair Professionals, and so you're in a great position to give us sort of a global perspective on training, education, and credentialing. So we know that the policies and eligibility criteria for wheelchair provision, as well as funding, vary greatly from country to country. But the question is, are there universal principles that can give us a place to start? For example, the WHO has developed 4 wheelchair service training packages to support people who provide wheelchairs. Those packages range from basic, which focuses on wheelchair provision for children and adults who do not need postural support, to intermediate, managers and stakeholders, and training of trainers. And that last training of trainers is for people who are training colleagues in appropriate wheelchair provision. Alex, from a global perspective, where is wheelchair provision in its journey, and is an international credential useful or even practical?
Thank you, Laurie. I just realized while I was sitting here, I set myself a little challenge to see how many times I could say South Africa in anything that I would say. So I'm going to take you back to when I was, not that long ago, a very young person that was in training in South Africa, doing my occupational therapy. And the sum total of my wheelchair training was a 45-minute lecture and then being wheeled around by a colleague for about 2 hours around the campus. You can imagine how that went down with the rest of the colleagues at the university. So not much investment was done in my training when I look back. I then went on to work in the UK, which has a heavy investment in terms of training and qualifications and credentialing around seating and positioning. And even when I look back, we still didn't get things right there. We still had issues. We still had patients coming back to us and saying, we need to think about that innovative model about how do we move things forward and be more forward thinking. So I think where we're moving forward in terms of an international credential, is this even possible? I don't think that we have figured this out. And I'll be the first to say that this is something that we need to work towards. I think that for me, first prize would be to have one internationally recognized postgraduate degree or qualification, but that's not really possible for many low-resourced or even middle-income countries or even high-resourced countries. So I think that micro-credentialing is something that we could look at, and looking at stackable certificates where somebody can gain expertise in a particular field and then build on those certificates so that eventually they do have some sort of qualification that we can say someone has the title of a wheelchair professional. Thank you.
Thanks, Alex. Simon, I'm going to turn to you next. As the founder and director of the European Seating Symposium, I'd like to get your perspective on Europe, and in particular, the service delivery program in Ireland. So what training and credentialing are currently required to provide seating and wheelchairs in Ireland? That's my first question. From your perspective, are those training and credentialing requirements effective and sufficient for the work being done there? And if not, what changes or evolutions would you like to see going forward?
Which part was the answer? As I said before, everybody starts off with their baseline. And again, as one of my colleagues said here, you come out of college, whether you're a PT, OT, engineer, whatever, you kind of find this area rather than know about the area. So you've obviously known it beforehand, and you come into this area thinking that this is about wheelchairs. Well, it's not really about wheelchairs. You know, it's about the person, and every single client that comes in is different. So I agree with international standards, but what I can safely say is that when you leave college, it's all textbook learning. And that's, so when you go on, I have colleagues who are doing PhDs in this area at the moment, and you know, education is the fundamental aspect. So you start with your bachelor's degree, you go on to your master's, you go on to your PhD, and as you go through that system, you end up in a situation where you pick one particular area within seating, assist technology, whatever, and that's what you just can't buy. Because when I come to these places, you're now getting all of that knowledge in an hour, 2 hours, and you're listening to the bullet points. One of my big things at the moment is probably molded seating for the last 10 years, 15 years has probably been one of my big areas that we concentrate on. And the next I see is the standing chairs, and it's the barriers to an awful lot of this comes back to funding. So you have to have those credentials to sit in front of these fund holders and be able to explain that, you know, this is not about me looking for loads of money. This is about the person that I'm advocating for. And we're not, you know, in my position, I have to advocate for thousands of people because I know that the future is not now, the future is constant. And that's the difference. I mean, if I said to somebody here, you know, what car were you driving 20 years ago? You probably can't even remember. And the evolution of this area has come an awful lot. And we've got to be honest, it's come an awful lot from the manufacturers because they were the people that had the money to actually put into the research. Where when we look at the health service in Ireland is like, you know, as Mintzberg says, there's no country in the world happy with the health service, and that's correct because everything can change. What we do have in Ireland is that we have a free health service. So if you fight for it, you'll get something on to be sanctioned for funding. But what I don't want to see, and this is the big thing, and with ISWP particularly, it's the worst thing you can actually see is people around the world, and we come from, you know, first world countries, but there are people who don't have the funding for the basics. So they're not going to care about credentialing. What they're going to care about is people with the capacity and with the knowledge to come in and do something to help them. If I go back to when I started first, and I look at the technology that was available, it's just crazy in the last 20 years how it's gone. So what's it going to be like in 20 years' time? And I also think time when you get to a stage where you step back and you let the young people, you know, come in because they have the same passion that you had 20 years ago or even longer. But the best thing you can do with regards to education is to make sure that that path towards what they want to do is there for them. So when we talk about credentials, we talk about qualifications, that should be a given. I mean, when somebody applies for a job, you have all the credentials in the first place. But when you come into an area, there should be ability to grow. And I think that what these conferences do, particularly ESS, you get an opportunity to learn where the future is. And I'm going to shut up. Unless you'd like me to sing a song.
I feel like we should be taking a drink or something every time Simon says ESS. Deb, I'm going to ask you a similar question. I'd like to turn to you for a perspective on the credentialing landscape in New Zealand, though. What are New Zealand's current credentialing requirements for wheelchair provision? And concerning credentialing, what's working well? Which parts of the requirements do you think could benefit from additional expansions or changes?
Firstly, I'll say OSS, Melbourne, November. Just to give you a little bit of the New Zealand context, we have 2 national funding streams. So there's no state versus federal. They're national funding streams, so the same rules apply for every person across the country. And about one of the funding streams is for people that have got an injury-related disability post 1978, and they're covered by the Accident Compensation Corporation. And then about 80% of our people with disability have got a pre-1978 injury-related disability or a health-related disability. Previously, all of our disability support services were funded through the Ministry of Health, and last year we created the Ministry of Disabled People. It's called Whaikaha, and Whaikaha means to have strength, to have ability, and to enable ability, and to be enabled. And there's a intention to, with the word of, so it's Whaikaha Ministry of Disabled People rather than for, and that's to show that disabled people are leaders and partners in the new ministry. So the voices of people with disabilities are really important. We continue to be advocates, but it's been a really great, it's a credit to New Zealand, I think, to be moving to that. There is no medical necessity. There's no qualifying diagnoses that we have to show. People with disabilities have medical problems, but disability isn't viewed as a medical problem. And equipment is free. So it's needs-based, and the philosophy is on enabling good lives, where people have choice and can participate in their communities in roles and occupations that are important and meaningful to them. And one of the barriers to that is when we get it wrong, and this is where credentialing is really important. So since the late 1990s and pre-2008, we had an EMS accredited assessor scheme, and essentially you do have, for wheelchairs and seating, you do have to be an occupational therapist or physiotherapist to access the funding. And this is Ministry of Health or Whaikaha funding, that the credentialing is attached to that funding, so 80% of our people with disabilities. And the process pre-2008 was that your employer would sign you off to say, oh yeah, here's an OT, here's a physio, they can access equipment and do assessments. And as we know, the undergraduate programs, and it continues to be the same, have got very limited content. So for Seating to Go, where I belong, we weren't happy just signing people off, so we developed our learning and development program so that our therapists understood the knowledge and skill required of them. They knew what their expectations were and had a learning pathway. And the Ministry of Health at the time reviewed that existing scheme in 2008, and the drivers for that review were inequity and risks, and the risks were to people with disabilities, but also risks to the funders in terms of the cost of inappropriate equipment provision. And what they found in that review is that people didn't receive an equitable service, so it depended on where you lived, who your assessor was, what the outcomes were going to be. And for the therapists themselves, many people felt unsupported, and they weren't clear what was expected in terms of their knowledge and skill. And so there were some groups that were consciously incompetent, but then there were the other group that were unconsciously incompetent. so not knowing what they don't know. And it led to real issues with recruitment and retention. So we had fewer people wanting to enter the area because we felt we weren't providing great services. So 2010, the ministry piloted the Seeding to Go learning and development pathway. It was across the nation, and following the pilot, it was adapted to the current version. So for credentialing for AT, they identified in that review the 4 highest risk areas were wheeled mobility and postural management, complex housing, communication AT and hearing AT. So those require a specific postgrad credential. And for the wheelchair mobility postural management, there's 2 levels. So level 1 credential is for non-complex, level 2 is complex, and then we also have lying, supported lying positioning and custom complex. To get the credential, you do a core module, which is an online module around funding. But then you do the learning and development program for either level 1, level 2, whichever credential you're going for. And so it's not an exam. And I think, just reiterating what Simon was saying, we learn by doing. And obviously we also learn by listening, but the hands-on is really important. So the credentialing pathway is that you do your core module around funding, but then you're getting into the 8 steps of wheelchair service provision. And the credentialing pathway focuses on the assessment process, initial interview, the trial and prescription, fitting and training. So it covers those areas. There's mandatory workshops that people need to do. And then back in their own world, they have to complete, there's about 12 different learning tasks that some of them are your practice being observed, some self-directed learning, but there's a range of activities that people need to get signed off by a supervising therapist with a similar or above credential. For the level 2, which is our more complex, we're required to submit a case study to a ministry appointed auditing panel of experts. So you complete your learning and development program, submit a case study for the level 2 and the custom complex credential. So not an exam as such. So what's working well is, or what isn't working well, I'll finish on a positive. The undergraduate programs still have really limited content. The credentialing process actually isn't mandatory for our ACC assessors, so for people with an injury-related disability. It's dependent on your employer deciding whether they'll follow the Ministry of Health pathway or the Whaikaha pathway. And for some therapists living in more remote areas, it is difficult to access a supervising therapist to sign off on the competency pathway. The ministry panel that does the case study audit is voluntary, so it's unpaid. So there's no real incentive for people to do that work, and it can mean that the case studies to get the outcome of your credential can take longer than is ideal. What's working well is that the ministry subsidises the training. So 50% of the training costs are subsidised directly by the ministry. So they are actually driving the credential. They require us to be credentialed. To try to make training more accessible, there's more hybrid training available, so online, not taking people away from their workplace. And there's been an increase in the number of people now being recruited and retained within the industry. And we used the ISWP Wheelchair Educators Package calculation on how many wheelchair and seating professionals you need for your country. And so the calculation for New Zealand is that we need approximately 485 personnel. And we actually have 656 who have the level 1 credential, and of those, 131 have level 2, and 259 have the lying and custom credential.
Thanks. Thanks, Deb and Alex and Simon, for that global perspective. We're now going to shift to the United States for these next few questions. Matt, I'm going to start with you. In addition to being the program manager, disability accommodations and clinical services for the University of Pittsburgh Medical Center, and in addition to teaching at Pitt, you're the president of United Spinal Pittsburgh, and you're a wheelchair user, busy guy. So that means you've seen wheelchair provision in the United States from multiple angles, including as a consumer whose daily life is impacted by the quality of American wheelchair provision. I assume that your work at United Spinal also means that you hear a lot firsthand from people about what's working and what's not working so well. Do you notice any commonality in the difficulties that wheelchair riders express to you about wheelchair provision? And do you see any training gaps or knowledge gaps that we need to address?
Yeah, so one of the things that I have to start with is that I'm very fortunate to live in Pittsburgh, and the knowledge of not only the therapists, but also the physicians, the providers. I didn't want to give a shout out to Mark this morning, but I'm going to. But the clinic here in Pittsburgh, the Center for Assistive Technology, I know when I go there, I can absolutely trust and understand that they're going to do the best for me, because everybody that comes in there from a provider perspective has an exponential knowledge of wheelchair provisions. That being said, that's not something that everybody in the United States has an opportunity to have. Just having a physician that has the understanding of wheelchair users is difficult in itself, but having the understanding of appropriateness of use of wheelchairs from a provider perspective is tough to find. I think Simon alluded to it in his country, but also here in the United States. Not every physical therapist and occupational therapist and doctor is going to understand the needs of a wheelchair user and the needs for appropriate use of different technologies. So again, very fortunate to be here in Pittsburgh as a wheelchair user, except for the hills. But when we think about some of the issues that we run into as wheelchair users and the provision of it, it's not always just about getting that equipment in the beginning, but one of the biggest issues that wheelchair users are facing is access to the right equipment and the right technology, as there's so many great things that are coming out from new technology, but it's not always accessible to wheelchair users. But we also have to think about, once that person has their wheelchair, what does it look like from a repair perspective and also from a maintenance perspective? So I would say that's one of the biggest issues that we're facing right now as wheelchair users in the United States, is really looking at the repair and the maintenance of that wheelchair. And I think that's an opportunity for wheelchair users, advocates for wheelchair users, industry, and therapists to really come together and work together and say, this is what needs to be fixed for wheelchair users, and this is how we can really impact the life and improve the lives of people with disabilities, to have that opportunity for better repair and better service for wheelchair users, as to improve the longevity of the wheelchair, but also to improve the longevity and the health of wheelchair users as they go through their daily lives using those wheelchairs.
Thanks, Matt. Helen, I'm going to turn to you now. We're going to see actually what has been accomplished by a field that does have quite a bit of overlap. For example, students in both orthotics and prosthetics and complex rehab, they take the same classes, they go through the same training, but obviously O&P is much farther down this road on the policy and funding path especially. O&P has its own separate benefit category under Medicare, but early in its development, the O&P industry required no formal training. And while today it does require a master's degree to practice, so quite a lot has changed. Helen, can you take us down that timeline of how the O&P field decided to require very specific and very formal training for its members, why that decision was made, and what the outcomes have been of those decisions?
Sure. So prosthetics and orthotics, like a lot of healthcare disciplines, in the very early days started out with experiential pathways. You went in, you did a lot of work in that environment, and that's how you became the expert. And then, we started to introduce the needs for specific levels of training and education, all across kind of slightly different timelines, and usually behind our friends in PT and OT. And prosthetics and orthotics in many countries, in many settings, and the US included, started to do a voluntary, self-regulating credential, right? We started going down through those pathways and beginning to kind of establish what we thought is the minimum standard, and having people that were communicating in all of the same ways. And things that are happening in the United States are kind of happening in parallel in the global perspective. And in around it's 1968, I think it was the European, and 1970-ish was large-scale meetings around the discipline because of the lack of access to good quality service in so many places around the world. Even today, there's lots, like the United States has 13 schools in prosthetics and orthotics, but it's one of the few countries that has any more than one, which gave us a really strong international cohort of people who wanted to come together and share and collaborate because they didn't have somebody at home to do that with. So as those things came along, they had these scientific meetings that were primarily focused in Europe and North America. I didn't use the other words, but, and they really established that when they looked at the kind of level of knowledge and understanding that people needed to have at the baseline, was at least a university degree. So people started working from there. And then around that time, the International Society for Prosthetics and Orthotics was formed, making a much stronger collaboration. ISPO became kind of a sounding board for the World Health Organization, and they had a formal collaboration. And in the early 1990s, they set out education standards where they essentially said, it doesn't actually matter what country you're in or what setting you're in. This is what you need to do good quality service, and it doesn't change, right? There's more or less technology, so there may be higher levels of understanding or more decision-making or different things in some settings, but this is the minimum. This is what everybody needs to know. And they broke those down into 3 classifications, categories of people who would be educated. And so we see these happening in the United States. They mostly, some of those categories, like the associate level now, which was the category 2, that actually started in low and middle income countries and has been introduced into the United States as a care extender, right? We start to see this framework come together, and people start to work on this. And it becomes very clear that these things stack into educational programming, and it's the same everywhere. It's pretty much the same everywhere in the world. And as we move along, going through these categories and working through these standards, we thought we were doing a really great job. Everybody was going to know what we were doing. Everything was going to be wonderful. And we would go in and we would lobby and advocate, like in ministries, in government offices, and try to explain what these categories were and why they were important and where they should be, how much, what was the salary level for somebody at this category. And it was really clear that people didn't know what we were talking about. It was just like, this is unrecognizable to me, because the people who are setting policy and establishing funding and moving through all of these things, they're accountants. They are people from other disciplines that went to very traditional academic settings, and that's what they know, right? They don't know what an ATP is. They don't know what a Category 1 prosthetist is. So there was a very active decision in lots of areas, starting really around the early 2000s, where we recognize what exactly the skill level is that we need to get to, and that does stack with some traditional education models. And programs here decided that it was going to be a master's level here. We do not exist in a vacuum. We need to be able to work through our evidence base and communicate with other professionals. Those professionals were going up to doctoral degrees. We couldn't not go there as well. And we knew that we had an extreme shortfall in our profession, right? Even now we're projecting a 60% shortfall in the United States of qualified providers in prosthetics and orthotics. We do not have enough professionals entering the field. And they knew that they didn't have enough schools, they didn't have enough opportunities for training. The hands-on of individually training somebody one-on-one in an apprenticeship model does not make any sense in prosthetics and orthotics and other disciplines as well. So they decided they would go to a master's. We were already at a certificate level, post-baccalaureate certificates, those kinds of things. And if we look at educational transnational frameworks, those are supposed to be the same as a master's, but nobody knows what that is, right? So the United States said, we are going to a master's, and we are doing it to ensure this discipline is sustainable, that the quality of the providers is appropriate for the complexity of the service we provide. And what they found was not only did they increase the number of schools that they had, they increased the volume and quality of candidates applying to those schools. We're still not there because the need is getting bigger and bigger and bigger, and we still have a very complex way of moving forward. But a lot of things changed as we moved through this in parallel in the international community and in the United States, where they moved to the masters at around that same time. ISPO started looking at our standards, and then starting to investigate a little more deeply into how we were not getting it right yet. And starting to look at things like the International Labor Organization and its classification of occupations. And somebody threw out a comment at a meeting, something like this, that said, prosthetists and orthotists aren't even in the International Labor Organization's classification of occupations. And there was a whole kind of scrambling around, and everyone thought, that can't be right, that can't be right. And no, it was wrong. We're in there, but we were in a group called Other Medical and Dental Technicians, in a major group 3 in the skill level of a level 3, which is like the second from the highest. Still pretty good, but not very well differentiated. And as we went through this, we realized, occupational therapists and physical therapists were in the highest skill level, and we were not considered to be there. But we also realized that as we went through in our international context, that we weren't meeting that standard to be in that classification for rates of pay and for that kind of trust within the bean counters who are counting beans. And just recently, we've realized in the United States as well, we're still in that category of technicians. We're not considered clinical healthcare providers because of these classifications. And did a little search to see where wheelchairs come up. Wheelchairs come up in the major group 7 with bike repairers at the skill level 2. I've been in a lot of these sessions. I don't think that the skill level 2 accurately reflects what experts in the wheelchair sector do. And I think one of the things that we really, I spent 10 years on the standards committee for ISPO education. One of the things that we need to be able to do is stop talking to ourselves. We know we're experts. We know how much work we put into it. We know what those skills and competencies are, but trying to kind of take a step back and make sure that we are communicating accurately. What is the competency? What do people need to know and understand to do this? And to set the level correctly. And that's really what P&O has focused on. And in every country in the world, we have seen rewards. So I used the example the other day of the Philippines that had no education. They had a small number of clinical service providers. And we had a major donor walk into a hospital room and met a woman who just had both of her legs blown off. And she looked directly at him in the eyes and said, "What are you going to do about it? Because I can't get legs here." And he said, "We'll start a school." And that was the 3rd week in September. And by the 1st week in November, they had signed an MOU. They were building a building. And I moved to the Philippines in January. By the time I'd been there for 2 or 3 years, we were in the presidential palace having a funding package so that people were getting access to those things. They had spent 30 years in smaller measures and stepping through people who were working really, really hard. But until there was that institutional level, policy level, and government level understanding of what it is you do and why it's important, nothing else was going to happen. And I think the same kinds of things happen everywhere in the world all of the time. So it seems like it's a very pedantic thing, but it's so incredibly impactful when you do it right. So
Thanks, Helen. Kyle, we waited till the very end to ask you, because I'm going to ask you to sort of offer up a funding and policy point of view, taking everything in from what you've heard. We've heard what consumers are saying, how it's worked for prosthetics and orthotics. You've heard about perspectives from other places in the world. So we know, obviously, that wheelchair coverage and reimbursement are constant challenges in the United States. How do you think credentialing impacts funding? That's my question for you. And do you think credentialing changes, for example, requiring additional training or degree programs, could improve funding sources' willingness to pay for complex rehab.
Thanks, Laurie. I think, can you hear me? There we go. Thanks, Laurie, again. I had thought about my response earlier before the session started. And in full transparency, I'm sitting here thinking, okay, now what the hell do I want to say? And the fact of the matter is, because listening to these astute panelists that I'm working with today and their funding source or landscape in countries outside of the United States, I'm sitting here being kind of frustrated, to be really transparent with you. You know, in our provision process in the United States, I'm thinking of, why are we doing it? Why are we exploring these credentials? What's the means to the end? And my initial answer is, the transparency vulnerability comes out, is it's for the funding. And I'm thinking, that's the wrong reason. It's for the consumer. But that's not the landscape we operate in the United States, right? That's the frustrating part that I'm all feeling right now, listen to these panelists speak, Laurie. The reality is, though, that the credentialing today, knowing that we're doing this, and we absolutely have to keep this paramount, that it's for the end user, the consumer, what we're doing. The securement of funding is the means to an end, right? But we have to hold paramount that end user's view and experience that this credentialing is driving that patient outcome. That's where I guess I'm thinking about it. And then I think about, from a broader perspective, is, well, who the hell is driving the bus? Is it the payer? Probably. Pisses me off, to be honest with you guys. Sorry to be just realistic with you, I guess. I think about, well, then what do we got to do? Helen, you were talking about that, to show that value, that patient outcome, the credibility. This is all the stuff we talk about this all the time. How do we convey that in a message to that it's not for the funding, it's for that patient? How are we able to do that? That's the part that I just struggle with, And then I guess your second question, Laurie, you asked about how the credentialing changes could improve payers' willingness to provide funding for AT. And I don't want to be a Debbie Downer, but I think it could. Is it right now? I think we're making progress. We see the advocacy groups from CTF in the United States and NCART and NARTS and RESNA, and it's going in the right direction. Sometimes it feels like it's the same stuff over and over, but we are making strides, Hopefully with the provision for seat elevation to come through shortly is a great thing to see. But I do believe that it will continue to take a holistic approach from the groups in the United States that practice, and internationally for that matter. Knowing that my lens today has been broadened from the US to outside of that realm. But it's going to take the efforts from the clinicians to the manufacturers, advocacy groups, academia, and providers like myself. And I will say this right now in front of all of you, that it's going to be a bipartisan approach from independent providers to national providers all across the United States to drive change. And I'm willing to do that. That's what it's going to take. If you guys want to talk later, I'm happy to discuss that, how we do that and strategize together as an industry for the end user. That's what I'm looking forward to.
Thanks, Kyle. I will throw out, I think, a little pitch for United Spinal is currently collecting stories, I believe, on wheelchair denials, and Jeannie Minkle is working with United Spinal to sort of sort through those. So if you have wheelchair denial stories from clients, United Spinal is collecting those to kind of pull together this, I guess, batch of examples that you can use for advocacy work. So little plug for Matt and his United Spinal bow tie. I don't know if you can see it from where you're sitting, but he is rocking the United Spinal colors today. So, okay, we are going to put up a QR code on the screen. If you could take out your phones, there it is. If you grab that QR code, and then I'm going to try to do tech stuff, which for an English major it is tricky. If you snap that QR code, and then I'm going to ask the awesome AV staff if they could show my screen, share my screen, because obviously I'm not doing that correctly right now. If they could share my laptop screen. There it is. If you can, you should be able to vote, I'm hoping. Oh, no, it's just told me you can't vote. Something went wrong. Reload. I'm sorry. But anyway, the question is, current credentials where I work successfully capture or represent the knowledge needed to provide wheelchairs, resulting in successful outcomes. And of course, it's just telling me, no, English major, you did not do anything correctly. Okay, there it comes. English majors we can fail if we have good audio visual behind us. Okay, so again, current credentials where I work successfully capture or represent the knowledge needed to provide wheelchairs resulting in successful outcomes. You can see the votes there. A little more encouraging than I would have thought, actually. And we're going to transition with this QR code fun. We're going to transition to the interactive portion of our presentation. There are actually 2 microphones, one in this aisle and one in this aisle. We're going to ask you to please, if you can get to a microphone to ask your question, please come to a microphone, because if you shout it out from your seat, even if we can hear you, it doesn't get picked up on the recording. And we definitely want the questions to get picked up on the recordings. So if you can get to a microphone to ask your questions, I'm going to ask if you have questions for any of our panelists, and if you don't, I do have some. So I guess, okay, while people are thinking of their questions, then I will ask mine. This is great, because as an editor, I get to ask my own questions. If nobody else is interested, I have a whole list. We could be here all day. Okay, first question. How proficient are credentials, as well as prerequisites required to sit for a credential exam? How proficient are those credentials at capturing the knowledge and abilities needed by today's seating and wheeled mobility professionals? So are the current credentialing programs making appropriate demands of credential holders? Anybody want to take that on? And then we have a question over here. Nobody likes my question? Oh no, bad question?
In New Zealand, it's very clear what the knowledge and skill level required. What the required knowledge and skill level is. But the other thing is, with our ministry contracted assessment services, we have to report on outcomes, and currently we use the wheelchair outcome measure for all of our clients, and somebody, maybe Rachel McDonald from Australia, might like to actually do a research thing to see, is there a difference between the credentialing process and post, to see if our outcomes are actually different. I think that's one of the things that we missed in the process of introducing credentialing, is that there wasn't a baseline measure prior to making the change. But it is a very clear process in terms of what knowledge and skill is required, and the outcomes seem to be positive when we use the outcome measures.
Thanks, Deb.
Can you hear me?
I think we'll turn it on.
As we said before, I think credentialing is paramount important, but we have to look at after the credentialing is the competency framework, in the sense that when you start to practice, that has to be measured across all the stakeholders. And that's down to your clients, the money, the inputs versus the outputs. And as my learned friend said, the bottom line of it is that we do have to deal with the accountants, the people who don't understand this area whatsoever. And not only do they don't understand, it's business to them, nothing else. So it should be taken for granted that the credentialing is there for the people working in it, but it shouldn't be taken for granted is the competency changes on a regular basis. So you have to be able to measure that. And there are several aspects to that. And unfortunately, it all comes down to the one thing is that the person who's seeing the client on the ground, are they doing the right thing? So we need to measure those competencies. And we also need to measure whether the client is happy with the service. One of my barometers, and I shouldn't be saying this because I've got colleagues in the room, is if I see a client coming back all the time. I go, well, why are they coming back? And so it's down to, and we're very lucky in our service in the sense that we have 2 people on every appointment. So you either have an OT and engineer, an OT PT, or a speech and language therapist, depending on what the client actually needs. So you end up in a situation, you've got this migration of learning into the prescription. And, some people don't like the word prescription, but unfortunately, after the client leaves and after you know what you want, you still have to find the money. And even though our health service is free, we need that clinical justification as to why we're spending, and we're like, complex rehab is not cheap in any country in the world. It's not cheap. So if you make the mistake, as you were talking about, that has to be paid for by somebody. And if the funding is going into mistakes, well, then that's, coming out of where it should be going. So I think the credentialing, and we get tied up in these. The other thing is, I don't know about it over here, it's impossible to find staff. So, you need to be able to attract staff into the area, but you also need to be able to make sure that when they come into the area, they have the possibility to grow. That you don't just come in and you say, right, that's it, I've got my credentials and I'm going to sit back and enjoy the rest of my life because I'm finished studying. No, you're not. It's only the start. Anyway, stop. And that's why when you go to the European Seating Symposium...
Alex, did you have a comment?
I'll be quick, because Simon takes up all the time. Yeah, just to add to that question, I think that Resonance ATP, I'm going to make a shameful plug for ISWP's certification for the basic and intermediate online training and certification courses, as well as Seating to Go's posture mobility training. I think that in order to access the certification program, we do need to put some minimum requirements, and some of the things could be like having some form of qualification in the rehab sciences field. And if someone hasn't had any qualification in the rehab sciences field, then perhaps they could do some training in those areas. They should be able to demonstrate that they have worked in the field of wheelchair and posture mobility. But as we've seen during the pandemic as well, that more and more training has become online. So I think having digital literacy is something that we need to be able to build into our training programs and credentialing. But bearing in mind that, again, in low resource settings, that people have limited access to data and electricity and connectivity and things like that. But I do believe very strongly that as we move forward in this sector, we've got to move the mindset from wheelchair provision is part of the donor provision. And in order to do that, we have to raise the bar. We have to have the standards. And in a few weeks' time, we're going to be launching the wheelchair provision guidelines at the ISPO conference. Yes, you heard me right. We're going to be launching the wheelchair provision guidelines at the International Society of Prosthetics and Orthotics. But yes, this is going to be an excellent tool for countries to be able to improve and develop wheelchair service provision. But another thing that I wanted to mention was that the wheelchair educators package that was developed by the International Society of Wheelchair Professionals is an excellent resource and demonstrates how much is being done in improving curricula in many countries. So if you haven't had a look at it, take a look at it, because there's a lot of resources available to build into that. Thank you.
And I'll be super short. I think the short answer is no. The longer answer is that there's work to be done. I'm somebody that is very particular about my seating and wheeled mobility. I spent countless hours with my therapist. Thank you, Rachel, for spending those hours with me. But just to make sure it was right. But I think we all have seen really bad wheelchair provisions as far as prescriptions. You look around any room of 30 wheelchair users and you're going to see some really bad ones. And I think that's something that, as a wheelchair user, it's noticeable. And I think that's something that, that person may not know how bad it is. And really that's when we look to the provider and say, how can you help us fix this problem?
Thank you.
Laurie, I might add, hold on, there you go, okay. I might add to that. Matt, thank you for saying that, by the way. That was my challenge to us, to say, let's look at it from a different lens, rather than credentialed or licensed individuals here, but from the consumer. So I'm glad you said that, Matt. I also wanted to ask, well, do we need to ask the payers, but knowing what they're going to say. But I also think there is some data showing, I think, some positive outcomes from the ATP credential, at least in the United States anyway, with US Rehab and University of Pittsburgh's Functional Mobility Assessment, the FMA. The data shows that when an ATP is involved in that evaluation procurement process, the quality of life metric for those individuals is increased. So we're starting to see the data that there is value to have, well, we know there's value to that, but showing the value to what we do is meaningful. So.
And I was just going to add into that a little bit about making sure that you are actually driving the evidence base in your own industry, right? That somebody else isn't being the researcher, that those researchers are coming from ATPs and setting up those outcome measures and whatever the studies are, right? That industry, the profession is supporting their own body of evidence. And again, I'll use an example I use all the time about ISPO doing studies on technology in low and middle income countries. And they investigated the same component parts, a Jaipur leg in Southeast Asia and in the Caribbean, and they got very different outcomes. And it was the old category 1, the highest level training in Vietnam. They made these legs and they only lasted for 2 years. And they went to the Caribbean and they had an occupational therapist and a handyman making the leg, and they lasted for 5 years, right? So if I'm the funding agent, who am I going to pay to do that job? Occupational therapists, right? But when ISPO did this study, they were able to go in and look at, was the person employed? How far could they walk? This leg lasted for 5 years because they didn't have a job and they couldn't leave their home, right? So they had a leg and they were happy. The patient satisfaction survey was like, I have this beautiful leg and it fills up my pants and no one knows I don't have a leg. But realistically, they weren't getting to participate in the world around them. They couldn't care for their children or have a job. And if we had let occupational therapists do it, they would have went, we can make legs that last for 5 years. So really focus on making sure that you are driving both what you're measuring and how you're communicating it as an industry. Because the credential is one thing, but if you're not actually doing the body of evidence driving that and talking, I always describe prosthetic orthotics, the people that we serve, as users, because they're in the same boat, right? Their outcomes are being pushed by funding agents who maybe have no idea what's going on. And they're being lobbied by maybe nursing and occupational therapists. I mean, for P&O, there are hundreds of thousands more nurses, and they can point and say, our outcomes change this many billions of dollars in wound care or whatever it is. We're much smaller than that, so we need to do a much better job in assistive technology as a whole, and making sure our evidence supports what we claim and making it accessible to those people who can make the decisions.
Okay, thanks. The most patient person ever waiting out here with a question.
Is this on? Can you hear me? Yeah. So my name is Cindy, and I'm a physical therapist, ATP SMS from Denver. And I just wanted to talk about, I think, the area that's difficult to talk about with the word ethics being in the title of this presentation. But I agree that credentialing helps add trust to our professions. And I think it's up to us to also protect that trust. And so along those lines, I think that credentialing comes along with accountability. And so right now, what I sense for accountability is just by rumor and reputation. You know, there's that supplier that may not do things quite the way we want them to do it. Is it unethical? Is it illegal? I don't know. There's a therapist that maybe doesn't know really what they're doing. Is it illegal? Is it unethical? I don't know. But there's no way to really track that, to look at that. And along with looking at somebody's ethics and practice, there's also the opportunity for counseling. Maybe this person doesn't know what they're doing wrong. Maybe they don't have the resources to correct what they're doing. And so most credentialed professions, I can speak specifically for physical therapy, have a board of ethics, an ethics committee, where a client, a colleague can submit a complaint and have that reviewed. And I know that we're a ways away from that, but I think that's something we need to consider. If we're going to be credentialed, and we need to be accountable, and we need to have a way to follow up to make sure that our professions are providing that trust. Thanks.
Thank you. That's a great comment. I mean, we haven't really talked about the a standard of ethics, or where that fits into the credentialing process, how important that is to determine whether someone's going to be capable of good provision.
Yeah, and I think that in really well-established disciplines, usually your credential is holding you. I don't know enough about ATP to know that it's not there, but there's usually a scope of practice and canons of ethical or characteristics of ethical behavior that you're held to. And if that doesn't exist, there's a bit of a problem there, especially if you don't have a way to enforce and you don't have mechanisms that people are accountable to, if you don't have characters of fitness or ethical conduct or any of those kinds of things. So that's probably something for a larger organization to maybe it's RESNA, maybe it's ISWP, to actually outline those, because ethical is the same everywhere in the world, right? You know, the do no harm standard shouldn't change no matter where you are. And as professionals, there should be a risk to you if you breach that, right? You want to have an ethical standard and a credential. That is a problem if you lose it, right? You'll hear people say, I want you to do this, and a prosthetist will go, I'd lose my license if I did that. We're not going down that route. And it's a showstopper, right? People don't kind of try and push those envelopes in the same way. So if you don't already have it, I would recommend that.
Okay. Kyle.
Yeah. Can you hear me? Hello? Okay. Cindy, thank you for that comment. And as a member of the Professional Standards Board at RESNA for the ATP and SMS, your comment does not go unnoticed and is very much acknowledged. As some of you know, we just revised our Code of Ethics and Standards of Practice. And actually, Julie Purano presented yesterday on the PSB as a whole and what that looks like. So I guess I'd love your comment about that. And outside of our test exam development and going through that cycle, the top priority outside of that is ethics and standards of practice and adhering to that as part of our credential. So Cindy, I would ask of you, I think you're over there, connect with me afterwards, please. I'd like to talk to you further about that.
I think we have more questions. Yay.
Hi, can you hear me? My name's
Yes.
Leah. I'm a physical therapist from Cleveland, Ohio. I was kind of wondering, after yesterday's talk, about how is there a plan to decrease the barrier for diversity within this field? So we don't have a lot of diversity within PT, OT, and so that trickles down to ATP. At least, I mean, maybe not everywhere, but where I did my schooling and in the setting that I work in, it's not very diverse. And so is there any way to decrease this barrier to entry or to encourage any sort of diversity programming?
I'll speak to that maybe from the University of Pittsburgh standpoint, because we've had a lot of conversations about that. Certainly, I don't know how long those conversations have been going on. I've only been with the university the last 3 years, where they've had a really strong focus on diversity and inclusion. At the same time, the American Board for Certification in Prosthetics and Orthotics, they've also had the same realization that we have a population that is underrepresented in our clinical factions, and that is true across most health disciplines. We have seen, particularly universities, different education institutes and organizations really try, but the reality is it's a grassroots effort, right? It's about getting out into your community and communicating with the people who are live and work in the centers near you, encouraging students into those things by going and doing a professional development talk with them, inviting them into internships or shadowing experiences, and really targeting, because we're a master's program, we are going to target historically Black colleges, for example, where we're going to go to those schools and invite those people to come to a talk and become aware of what P&O is. Because in the good old days, you learned about it because your dad was a prosthetist and he made you come in and help clean up on a Saturday. That's how you did it. And so it kind of has this self-perpetuating cycle, and we've seen a lot of turnover, right? The last 20 years, we've seen it go from a man's job, the blue jobs and pink jobs, to a very gender diverse in terms of the male-female categories, but we also see the LGBTQ community is underrepresented. Those people are in all of our communities, and the better we do in representing them. But I would say that's a call to action for everyone in the room, that if you want to make sure you can best serve the population you see, you need to help to get that message out there, because there is no other way to do it. We're just all of us are small professions, little known. Physio, everybody knows physio. Seven applicants for every one seat in a physio school, right? And if you could make some of those more diverse, wouldn't that be great? Maybe you'd end up with 10 applicants for every seat. It wouldn't be better, but yeah, I think it's for everyone here, and it's an easy lift, right? We're the most fun kinds of professions there are, right? Hands-on, wheelchair. I see them, the MRT and the MSPO students going around the CAT in powered wheelchairs and like using like head controls, and I'm like, I want to be an MRT, right? This is an easy sell, so invite them and try and partner with institutions that'll give you the demos to take it to the school, right? That's my suggestion.
I would add on to that, at least from the ATP perspective. I know there's affiliations in the United States that are looking at a pathway to an ATP that can bring the entry requirements down, so there is that intermediate access to help drive candidates that maybe wouldn't have historically been able to sit for the exam based upon some of the requirements. So that is going in the right direction, but I'd actually throw it back to one of these panelists that have a different landscape than we do in the United States to that payer landscape. How has that looked for you guys, like Deb in New Zealand? I'm curious. I don't want to put you on the spot, but really curious.
I guess one of the steps has been the creation of Whaikaha, so the Ministry of Disabled People, so that, like in terms of minority groups, just try to have that voice heard. I know that there are allocations that are set aside for the OT and physio schools that are for Māori and Pacific Island, and that people are encouraged to move into those professions. So there is an active process for trying to encourage some of those less represented groups within the schools.
Yeah.
I can probably also add to that. Obviously, I come from South Africa with our bad past history of apartheid, and I wasn't clever enough to get into medical school. And for the Indians in the room, every Indian family and parent wants their son or daughter to become a doctor. So I had to find something else to do. And in occupational therapy at the time, post-apartheid, they made an active effort and became intentional about changing the demographics of those who went into allied health professionals. And so they actively were seeking for males, non-whites, and so there was this active case for people to go into that. But I do believe, like Helen says, I think this is a call for all of us that we need to take action, and we need to be able to mobilize in our own communities and let people know that these are the professions that exist out there, and take action and tell people that this is what we need to do. But I think ISWP is quite well placed to be able to work within our networks across the globe, to be able to work and advocate for going into schools and colleges and getting people to know more about the profession. Yeah, thanks.
Okay, thank you, Simon.
One of the biggest things is the barrier to education. I mean, you don't start your life thinking, I'm going to be an engineer, you start your life as a child, and you start school, and in Ireland you start school at 4 or 5 now. But an awful lot of people don't have the opportunity and don't have that. You're only as good as your parents in the first place that make you go to school and make you learn. But what we need to take away, and it's not just about our profession, it's about every profession, is the barrier to education. And the biggest barrier to education is the fact that it costs a fortune no matter where you go. Now, in Ireland, it's free, apart from the registration fee, which is about 4,000, which is going back down next year. And that has been a huge impact because the student didn't have to find that money. When I listen over here to what you pay, I go, that's a mortgage for a house. And that's a big barrier. So if you're going to do anything, you take away those barriers first, because unless you're rich, you're not going to be able to afford to get this credentialing. It's going to be impossible. And that's why when you come to the European Seating Symposium, we tried to keep the cost to a minimum. And we also, at the moment, your president is in Ireland, so he sent me over here to look after the shop. But I hope that you lobby your politicians, you lobby everything, because unless you get the educational costs down in this country, you're going to go nowhere.
Thank you. Do we have one question? We're going to try to sneak in one last question real quick. Yes, please. Thanks.
Hi, my name's Alex. I'm a new ATP in the industry. I've had it for about 6 months now, and I think that's a good segue I wanted to bring up. I do think the credentialing adds legitimacy, and I think that's wonderful, but with the higher education, I feel like in the country and getting the younger generation to be into our industry, I worry that I think there's a new study that 40% of bachelor's degrees holders aren't even having a job in their field, and the higher education is kind of under scrutiny these days of it being worth it. It's being so expensive, so I worry that increasing the credentialing requirements might also negatively impact the newer generation getting into the industry. And I don't know if you had any thoughts on that.
Thanks for that comment. We have one of you can talk. So sorry. We need to get the code. We need to get the code to people.
So I think there's a whole lot to unpack there, right? I know our time is really short. What I will say is, in the UK where you can get an education for free, in Canada we have subsidized education, and you pay, or Ireland, sorry. Whoa. Sorry, I didn't know whether he was north or south. I could just hear the accent. Yes. Well, Scotland, for example, their P&O program is free, right? So there are. My point is, in those places, we actually pay taxes, so I'm still paying for my education, right? I never got out of it. I just don't see the direct cost. So the cost is still there, even if it's not on your personal bill. It's a choice. I think I would agree. The cost is really high. It's very challenging to meet those costs, but it's a decision that you can invest in, and also to for all of us to look at stacked and ladderized programs where there's an exit point. To try and find different ways to do that. In the United States, people come out with huge amounts of debt, and that needs to be reflected. We have this in P&O where people can say, they come out with the masters and they want all this money, and it's like, we haven't had an increase in the fee schedule, so I can't give them more money. And that all goes back to that advocacy, that showing what it's worth. There are professions like lawyers who charge you for thinking about it, right? So, $400 an hour while somebody is thinking about it versus somebody who is changing someone's life and bringing them back into these things with a much more complex set of scenarios that are happening in front of you. You're asking for that education cost to come down, but maybe what we need is the reimbursement to go up, right? Is that trying to look at it about where you're paying for it, right? To say, I'm still paying for it. You're still paying for your education because you paid through your taxes.
Easy.
No.
We have to give people the code.
No.
Stop. Quick.
What?
Quick.
Oh.
Because we're out of time.
I'm been told to shut up.
We're out of time.
So basically, yes, we pay taxes. But at the end of the day, we have the opportunity to pay taxes. And we have the opportunity to earn money. But if you don't get the education free in the first place, you'll never have that opportunity to pay taxes.
Okay, that's a good point. He's right. I apologize. Thank you to our panelists, Kyle, Deb, Alex, Simon, Helen, and Matt.